All right, we're right at 2 o'clock. So thank you everybody for joining our webinar. I'm going to bring up our panelists and myself. So Dane Christensen is here with me today. This is the first time we're doing a Zoom webinar, Ask the Experts Live. So we're really excited for this. The topic today is what happened to our IVIG home infusion bill. Giving just a quick background on the topic, home infusion IVIG is an accepted and often preferred form of treatment for CIDP and MMN patients. Sorry about that, had a technical issue. Is often a preferred and method treating of CIDP and MMN for patients. However, accessing home infusion gets a little complicated when somebody living with CIDP or MMN switches from their private insurance to Medicare. Because Medicare is run by the government, we have to advocate to the government to create policies or fix policies to make this more accessible for the patient community. So as I mentioned, with us to explain what's going on and how we're advocating on this topic is Dane Christensen from Health and Medicine Council. Dane is a managing partner at HMC and has been with us for many years doing the advocacy and steering our complicated policy work to help preserve, protect, expand access to home infusion, especially for IVIG. So thank you for joining, Dane. For all of the attendees today, thank you as well. Just a quick housekeeping note, we will take some questions from the audience. We have some pre-submitted and pre-written questions for Dane already, but if we want to pepper him with some more questions, please, at the bottom of your Zoom webinar, there's a box that says Q&A. If you click into that, you should be able to type your question and it'll come to myself and to Dane. And a special shout out to Ellie Herman, who's also on our advocacy team here at the foundation. Ellie is going to help us monitor these questions as well. If we don't get to your question today, please feel free to email us at info@gbs-cidp.org, and we'll work on getting an answer for you. All right, getting right into it now, Dane, are you ready to take some of these questions?
Absolutely.
Not to put you in the hot seat, but you kind of volunteered for the hot seat. All right, so first, can you explain the foundation's history in trying to improve access to IVIG home infusion for CIDP and MMN patients?
Sure thing. And in discussing that, I want to emphasize the importance of grassroots, we think of as personal outreach or advocacy, and even thank everyone who has shared their story or been part of this effort in the past. You know, this is how Congress makes decisions. You know, the old saying is you can be at the table or on the menu. So if you have a problem, like the inability to access home infusion, that's something that your elected officials, your senators and your representatives should know about. So I want to once again encourage everyone who's been part of that process, but even identifying the challenge in the first place comes from having people share their stories. So of course, the GBS-CIDP Foundation hosts events, you know, in DC, all over the country. These often have medical experts and they're attended by patients. And a common thing we had noticed a few years ago was many people flagging this issue of saying, geez, it's great you talk about out-of-pocket costs. It's great that you talk about way to lower personal expenses. But for me, the real issue is when I switch on to Medicare, when I was switched to Medicare, I used to infuse in the home and now I have to go to an infusion clinic. This is incredibly disruptive. So sharing those personal stories is what helps us diagnose these issues initially and come up with some potential solutions. And then sharing those same stories with Congress is what moves them forward. So this was something, as I mentioned, that came from the grassroots network about 6 or 7 years ago now, was people pointing out this pervasive problem. This was one at a time, but drops in a bucket, and you start to notice a trend of folks saying, I was infusing in the home, then I transitioned onto Medicare, and when I did that, I was not allowed to infuse in the home anymore, and I was forced to go to an infusion center. For some folks, they said, it's no big deal. I live next to my academic health center, so good for me. Other folks said, this is incredibly disruptive. I have to travel, 90 minutes or 2 hours. It's difficult to drive. My infusion can be 2 days, so I might need to have a hotel room and stay overnight. This is incredibly disruptive. So One of the things we try to do as a voice of the patient's group is make sure that we are preserving the doctor-patient relationship. So when a physician says, this is what we should do as a course of care, and you agree with that, that can happen, that there's a means to allow that, and no third parties are interfering with what might be the best course of therapy for you. And in that regard, the physicians also express similar frustrations when we approach them. Neurologists, others saying, I have patients who are going to an infusion center right now that I believe, in my medical opinion, should be infusing in the home for a variety of reasons. And we've been on the phone with Medicare, and our doctor, our hospital or doctor's office has, and they've told us there's nothing they can do. And we're incredibly frustrated. So I think, we have been trying to educate folks about this issue because it is unique in some respects to our community, and then also make sure that they can solve the problem and have it and get to a place where if you don't have to do home infusion, that's not the new requirement, but it's one of the options available to you if you and your doctor agree that's the best course of continued therapy, or if that's what you've become most comfortable with while being on private insurance and infusing in your home.
Yeah, that definitely really explains the issue and why we advocate on this. Can you talk a little bit about the history of some of the policy changes that we have tried to make at the foundation?
Sure. So I'm going to give some basic civics information. It's going to sound a lot like Schoolhouse Rock. If it's too remedial,
always helpful.
I apologize, but I hope this lays a foundation for folks. So first and foremost, of course, there's three branches of government. The two that we're talking about here, one is the administrative branch, the agencies. This is National Institutes of Health, which does research. Also CMS, the Center for Medicare and Medicaid Services, which sets all of your federal coverage policies and rules. Not private insurance. This is, they have guidelines for private insurance, but this is CMS, the government provided healthcare. And then of course, the other part of that is Congress, your elected officials. They make policy, they pass laws, they spend money in the federal budget on an annual basis. This is the role of your elected officials, and then the executive branch, which is the ones literally facilitating the Medicare, Medicaid program, but asking Congress, what does the underlying law say? That's what we're trying to do here as we deliver care. So that's the kind of overarching framework. And then within that, of course, if you want to pass a bill, as we all know, and I'm sure folks have heard before from a school teacher at some point, that bill needs to pass the House, needs to pass the Senate, needs to be signed into law by the president. That is the most basic process for getting a bill enacted. It must be done that way. Of course, there's a lot of details there. Bills typically go through what's called a markup process, where they go to a particular committee of jurisdiction. In the House, that's the Ways and Means Committee, which the name doesn't suggest it, but handles these healthcare issues for the federal government. There's an Appropriations Committee. There's a Law and Justice Committee, but we go to the Ways and Means Committee and the Finance Committee in the Senate. They review these bills. They at some point hold what's called a markup or a hearing on the bill. They answer questions. They think about what they're going to do, and then they approve the bill. And that moves the bill to the floor, and you can vote on it when it's on the floor. I think folks, if you watch the electing a speaker, earlier this year, you see how the vote comes up and everyone has to vote on it. You do the same thing in both chambers. The Senate has a similar process, but of course, the Senate can just pick up any bill that the House is moving that's passed, and the House can pick up any bill that the Senate is moving and has passed the Senate. There's also something called the suspension calendar in the House and the hotline in the Senate. And that comes into play if you have a bill that has majority support. So if you have, there's majority in the House would be 218 members of Congress. You have 220 co-sponsors on your bill. It says, geez, there'd already be a majority to vote for this. So instead of holding a vote, can we just do an automatic maneuver and pass the bill straight through? It's tough to meet that level of scrutiny, to clear all the hurdles and make sure nobody has an objection, but that path is available. You can hotline or suspend a bill. So getting more and more support is crucial, both for going through the committee process and also going through that kind of the other processes are available. The key thing is do you have support, and are the right people for, supporting the bill? So a lot of support, and that support in critical areas. The law that we're dealing with right now, not the bill we're proposing to change the law that we're dealing with right now is the Medicare Modernization Act of 2003. So, the government is like steering a battleship. It moves very slowly. We're updating a law that was passed in 2003, so 20 years ago. How common was home infusion 20 years ago? Probably not as common as it is today, but this is how the process works. Policymakers hear input from their constituents, and they know how to update these laws, some of which are increasingly outdated or older, to make these technical improvements. So the Medicare Modernization Act of 2003 provided a benefit. They've covered the cost of intravenous immune globulin to infuse in the home. That was put into the law, but then there was no provision to cover the associated items and services. Just the drug was there. So people couldn't use the benefit. It wasn't whole because the cost of the associated items and services was prohibitive. And and the government isn't going to figure out a way to say, oh, geez, well, the drug is covered, but let's work together and maybe you pay this out of pocket, or, we'll figure something else out. They just say, well, the drug's covered, but the items and services aren't. So, too bad. Providing the payment for those associated items and services then allows access to this benefit that currently exists, which is utilizing intravenous immune globulin for home infusion. So that's the policy change we're seeking. I think some of you may know this. The law also discussed immune deficiency or primary immune deficiency disease. That was the only indication for IVIG, I believe, at that time. So PID was mentioned, and the PID community, starting way before we did, said we need access to these items and services. So they worked to pass a bill that provided a temporary benefit to say, we're going to do a study. The government loves studies, they love data. So they said, we're going to do a study, but the study was really a vehicle to provide access to all these PID patients. So they said, we're going to cover the associated items and services, we're going to make the benefit whole, and then we're going to study it and review how it's working. The problem, though, is that study was only supposed to last a couple of years. And of course, when the study ends, then everybody who had gained access would lose it. They would go back to the way it was before. You would have had access for a couple of years and then lost it. And policymakers in the PID community said, this is not fair. We use home infusion. We've been using it now. You have to make sure this benefit remains because it's so important. So they extended that study a couple times just to make sure that patients could continue to utilize the home infusion benefit that needed it. And then in just the end of last year, they turned that study and made it into a permanent benefit. So the permanent benefit now exists for IVIG home infusion with a diagnosis of PID. I remember I mentioned that the government is a little outdated and very technical. The law says IVIG and the law says PID right now. So there's been incremental progress in this space, but we need to continue to make progress for the CIDP community specifically and ensure that this benefit, including the new benefit, no longer a study, now an actual benefit in Medicare that PID patients just gained, is wide enough to include the other folks that are using IVIG to home infuse, us, CIDP and MMN patients. So that's a little bit of the legislative process and where we're at right now.
So let me, there was so much good information in there, and I think it is really a testament to how the government works. So let's do a quick summary kind of everything that's going on. So we know that IVIG has been utilized. IVIG, by the way, stands for intravenous immunoglobulin, and it is FDA approved to treat CIDP and MMN in some cases. So we know that has been able to be covered by Medicare for a long time, but what wasn't always as popular was that home infusion. So when the healthcare system was kind of revamped and redesigned, which hasn't been for a while, right? There wasn't necessarily the broad benefit access for home infusion of IVIG for CIDP and MMN. So what we have been doing at the foundation, and Dane, I think the next question is going to be specifically about the last three pieces of legislation that we have introduced through our champions. What we have been trying to do is expand that access that does exist a little bit, and expand that access to the CIDP and MMN community. And like Dane mentioned, a lot of this can take so long and take a long time, which is why I think the community can sometimes feel so frustrated. So Dane, kind of thinking about, how long it takes and how frustrated people can get, can you tell us the incremental progress that has been made? So just as a refresher, we've introduced 3 bills, 4724, 2905, and then 3808. All of those have been in the House. And can you talk a little bit about what the purpose of those was and how far we got with each of those? And then specifically, we had a question come in, since HR 3808 didn't pass, does it go away? Well, we will address that a little bit later, but if you want to just start to touch on that.
Yeah, thanks, Chelsea. And I think we can discuss that in part of answering this question, which is, as you mentioned, so when we just had an election in November, those folks that were elected just started Congress on January 3rd, 70 new members of the House, 7 new senators. But that is the 118th Congress. And each Congress is in session for 2 years. So we're just in the start of the 118th. In next November, there'll be another election. And then in 2025, it'll be the 119th Congress. And so there's a 2-year time frame. And your bills are introduced there and that are there for that Congress. So the reason we've had 3 bills is that we've been working on this issue for 3 Congresses going back basically 6 years now. So and each time the bill has been improved or made more likely to pass. So the first time we did a bill like this, we were mainly saying, okay, we see that you did this demonstration project, this study for PID. We want to do a similar study. Please make us have a parallel study so you can do this for both of us. We had feedback from other stakeholders. It is an open process, so anybody who has an opinion on this can weigh in. Folks said, that we're experts. You really can't have the exact same study as PID because the CIDP patient experience is different. You have longer infusion times, you have more complicated healthcare needs. So if you say make us the same as PID, since the government is very draconian and what Medicare is doing is literally what it's told to do. This is the letter of the law versus the spirit of the law kind of thing. Since the law literally says cover this and do this with your coverage, we would have the same type of coverage as PID. And that wouldn't be complete for CIDP patients because it wouldn't account for the extra time, some of our different healthcare issues. So we made, the next time the bill had to be reintroduced, we made changes to make the project unique to CIDP. And each time we've raised more awareness, we've gotten more data to Congress, and we have advanced the process by building a critical mass of support. Susan, I'll just address your question really quick. PID stands for primary immunodeficiency disease. So that is, you think of the boy in the bubble, but similarly now you infuse IVIG, you get a healthy immune system. That's PID. Then after we made those changes to the bill, we also had some feedback that, well, I'll talk, about the what we're looking at right now, which is, now that the PID benefit has been enacted, as we look to how this actually makes the environment easier for us to move something forward now, because we're not asking Congress to study this issue. They just studied it. They studied it for 6 years with the PID community, and ultimately they created a benefit. So we were saying, do our own study. Now we don't need that study. We just need to make sure that the benefit that exists also applies to us. So we're talking with those key congressional offices, the ones who are big champions on this, and have been helping to move this bill forward, to say, how can we go to this new benefit and then make sure that it applies to CIDP and MMN as well. And it does so in a way that, once again, accounts for the different or more complex patient experience with CIDP and MMN. So the flexibility is there to cover everybody who needs it and wants to do it. So I'll mention really quickly that these issues reach a tipping point. Oftentimes it feels like you're pushing against a brick wall until everything kind of crumbles in front of you. And the next thing you know, your bill is heading to the president's desk. There was a bill called the Genetic Information Non-Discrimination Act, which passed, I'm dating myself, but a few Congresses ago. That bill is what many of us would think of as common sense. It says if you get tested for a genetic condition and you find out you're prone for breast cancer, for example, or have a gene that might make you more likely to get it, you can't be fired from your job by knowing that information. And a life insurance company can't deny you a policy because you took the initiative to find out if you were at risk for other diseases. We would say common sense issue. Of course, the government should fix that. It took 8 years to pass that bill, so 4 Congresses. And when it passed, though, it passed like 300 to 3. So it wasn't a case where you kind of just made it over. You built that support, you got to where you needed to be, you answered all the questions, and then you were on your way to enactment. So the one thing that the Genetic Information Non-Discrimination Act didn't have to deal with was 2 Congresses where COVID was the topic du jour in healthcare. And particularly the 116th Congress exclusively consumed with doing COVID work on the healthcare committees. You couldn't really have them look at any bill that was not COVID related. It made it incredibly difficult to even meet with members and talk to them. Of course, they were still available by email and Zoom, but the being able to get to their office, answer questions, follow up was incredibly meaningful. So I'm not saying that we're even further behind because of that, but what I am saying is that we're leaving COVID now. For the 118th Congress, Capitol Hill is open again. We can visit. I can go to an office and talk to my members of Congress. So can you. We are going to try to capitalize on the success we've had recently. We are going to try to pass the bill this year with those improvements. We're going to build on the champions we have, but it is not uncommon for a bill to take multiple Congresses to move forward and be enacted.
Thanks, Dane. And that did answer another question that came in, that how long does it usually take to pass a bill like this? And I think what I'm hearing from you is multiple Congresses. And we are on track for that. So HR 4724, HR 2905, and HR 3808 were all our previous iterations of legislation that would help to create that demonstration project, being that first step in creating the access to the home infusion of IVIG for the CIDP and MMN community. And along the way, we keep learning, right, Dane? We keep learning and we keep getting more and new champions. And we keep getting farther along in that process. And more importantly, too, we raise more awareness of the issue so that each time that we go through this with the new Congress, it gets a little bit easier because people are getting to be a little more familiar with that as well. So Dane, there's other stakeholders impacted by the legislation. Just very briefly, kind of 30-second answer. Can you talk a little bit about, why it's important that we build consensus with all of the stakeholders involved in this?
Yeah, so thank you, Chelsea. And I'll mention really briefly about that question. We are talking about a little bit of a niche issue that's unique to the CIDP community. So it's up to us, up to CIDP and MMN patients to carry this message to Capitol Hill. This isn't something that broadly affects, many different chronic or rare disease patients. So this is up to us to educate with those stories. Some of you might have noticed that one of the things that Congress did on a coverage and access issue recently, or this past year, was they established what was called a out-of-pocket patient cap in Medicare Part D as in dog. So if you're in the Medicare specialty drug program, you did not have an out-of-pocket cap previously. You had coinsurance, and this could get very expensive. Now, by 2025, they're phasing in a $2,000 maximum. So you spend up to $2,000 with the smoothing mechanism, and then you hit that cap. It took 6 years to make that change that I'm aware of. The community has been pushing on this, but this is a change that applies to every single patient with a rare or costly condition. So, it's not as if we should have every expectation that if we make our voice heard, Congress will be similarly responsive to us, but we have to abide by that process that's in place, even if sometimes it takes a little bit longer than we're comfortable with. What I'll mention as part of that process, though, of course, is everyone has a right to weigh in on any policy proposal. So we have made it known that we believe this access to home infusion is important, but congressional offices, contrary to what you might see on TV, don't like dealing with a lot of conflict. If there's disagreement about an issue, they prefer not to try to wade into those waters and play, referee and figure out what the right thing to do is. So one thing we always try to do is seek consensus with other folks that are part of the healthcare ecosystem. And that includes insurance plans, that includes specialty pharmacies, that includes manufacturers. Because if we're proposing a change that would be bad, they would have the knowledge to tell us about it. They might say, hey, this might seem like a good idea to you, but on our end, it's unworkable. So what we try to do up front is make sure everybody's on the same page. Everybody agrees with the switch so that congressional offices hear a consistent message about why this matters and why it's important. Because if anybody goes to their office and says, hey, I know you're working on this, but I have a different point of view, the congressional office is going to say, well, geez, I'm not going to take a bunch of time to sort this out. I have many other issues to work on. Our bill was HR 3808. That means it was the 3,808th bill introduced. By the time the Congress ended, we were up near 10,000. So it gives you an idea of how easy we have to make this for them to make sure it gets on their radar and they have a simple way to address it. And the key thing to do to make sure that process doesn't slow down is to make sure all the stakeholders that might be impacted have the same point of view and are aware of it and on board with it. So if anybody gets asked, they all say, yeah, this is a good idea and this is why I agree with it. So we do part of that effort of making those changes from Congress to Congress is that consensus building process and making sure we're addressing all different issues, points of view, and potential innovation. I did see somebody mention SCIG in the question section. I will make a point about that because it ties in with this discussion, but gets to how technical this Medicare area is and how important it is to raise this awareness with Congress. There is a Part B benefit for self-infused drugs, including, subcutaneous product. That was passed a few years ago through a bill called the Cures Act. That benefit, though, just applies to subcutaneous IG. It does not apply to intravenous immune globulin. And of course, if you have a manual dexterity issue or if you need a nurse to help you infuse, there's a difference between using a self-infused product and using intravenous product. As I mentioned previously, our mantra is all products, all sites of care, and preserving that physician-patient relationship. So while that option is increasingly available now, we want to make sure all these other options, including IVIG, are similarly available. But since Congress passed a law that was just for self-infused, that does not cover intravenous immune globulin either, and the associated items and services with that.
Yeah, thank you for that. And I think I want to mention too that you talk about the hard work that goes into building consensus on these bills. And that also takes a lot of time as well. So doing it the right way sometimes takes a lot more time, but it is so worth it in the end, right? So, Dane, you still with me?
Yeah, sorry, I was keeping an eye on the questions that are rolling in.
Oh, that's okay. And Ellie is keeping tabs on the questions, so she's answering some, and then she'll push them to us live. But the one thing I do want to get to is, and this is also pretty much the title of this Ask the Expert webinar, we get this question a lot, and you touched on it a little bit, but I think it's really important to drive this home. Why didn't the bill pass? So let's think about HR 3808 specifically. So you've mentioned kind of gridlock, you've mentioned the COVID issues. Why don't you elaborate a little bit on that and then talk about how the 118th Congress will be different?
Sure. So one thing I think is important for the last Congress, which is not always true, is that they passed very few healthcare bills. They held almost no markups. And a reason for that was they had been told by leadership, the markup process just isn't going to be as important in this Congress. So that was a little... Can
you just pause and remind us of what a markup is? So
the markup is when they hold a hearing on your bill, and then everybody on the committee, well, first the subcommittee and then the full committee, has a chance to vote on it and say, I agree with this, and they do something called reporting it out of committee. So the committee of jurisdiction has vetted it, they maybe amended it, but ultimately they passed it and said, this is good to go. And then they bring it to the floor of either the House or Senate, and it can be voted on by the full membership. So that is a process or a check that occurs with these different committees of jurisdiction, particularly the healthcare committees that we're talking about now. So the healthcare committees during the last Congress held almost no hearings. And you could say, well, geez, the members were just working virtually during COVID. Or you could say, geez, they just had other stuff. But the reality is that they didn't hold many of these for anyone at all. So, we were waiting for our markup. Markup never rolled around. There were a number of members who were expressing frustration with this. And the feedback that they had from leadership was, well, if you have an issue that you're passionate about or a bill that needs to move, we may just be able to figure that out at the end of the year. When we do what we normally do, is smush all this together in what's called an omnibus package. So there's a famous phrase that Congress works for crisis or Christmas. It means if they have a imminent thing they need to deal with, like the debt ceiling that we all see about now, or if the Congress is about to end, everyone wants to go home for the holidays, they need to get their work done. And, much like procrastinating in school or cramming for a test, then they do it all at the end of the year. So there were lots of assurances given out that many of these issues would be considered in that end of the year package. And then when Congress failed to do a few things that they needed to do, they were trying to do a bigger FDA reauthorization. They tried to do establishing language for this new entity called ARPA-H, the Advanced Research Projects Agency for Health. As their to-do list started getting everything pushed further and further back, the end of the year rolled around and they said, geez, we really need a way to figure out how we can handle this massive scope of healthcare bills. And then the decision was made. They said, well, we're only going to take the most essential and the most critical, and the other stuff we'll just deal with in the next Congress. So unfortunately, we were part and parcel of that dynamic. But also, looking forward, do not think there will be a similar situation this year. So the fact that we didn't get a chance to have a markup yet dinged us for that end of the year consideration. But the good thing for the 118th Congress is that the work of all of you to raise awareness of this issue and to make sure folks, particularly folks on these key committees, are aware of this is going to make it easier to move the bill forward in the 118th. So when it's reintroduced, we already have this year a number of offices asking us, hey, when is the bill going to be dropped again? Because they know how important this is from speaking with you, and they want to make sure that they're working on it. So Chelsea, I don't want to drift into too technical of an explanation, but if you need me to clean anything up, please go ahead.
Well, why don't we back up? I see a question in from the audience that I think is helpful. Who are our champions? How do we get more champions? Can you talk about who our key people are right now, who they've been in the past? And then we can do a little more of a deep dive into how people can get involved in helping us define champions.
Yeah, of course. So every member of Congress can have an impact on this. Even if you have a non-voting delegate because you're from Guam or the Virgin Islands or Puerto Rico, it still matters to educate your members of Congress about this. But basically, a Democrat and a Republican sponsor a bill. Our bills have always been bipartisan. That's essential to moving forward. Congress is not a tug of war. One side doesn't win and the other side loses. The only thing that moves forward are things that have bipartisan, so both parties, and bicameral, both chambers support. So we work to make sure we clear that hurdle. Our Democratic champion for many years has been Earl Blumenauer from Oregon, a member of the Ways and Means Committee, the Committee of Jurisdiction. He is still there, but now, of course, he's in the minority with the balance of power shifting in the House. Our old Republican champion was a guy named George Holding from North Carolina. He retired a couple years ago, but thanks to your work, we have a new Republican champion, a guy named Adrian Smith, who's also on that Ways and Means Committee. He cares deeply about this issue and his office is dedicated to helping. And he was almost the chairman of the Ways and Means Committee. So he was in the mix as one of three members that could have chaired that committee. He didn't get it. It went to a different guy named Smith, a Jason Smith from Missouri. Maybe that was just a clerical error, but his office is now very senior in leadership and very committed to helping us. But that's because of the work that's been done locally and their commitment to this issue. The other people who've co-sponsored this bill, the 20 plus folks that are on this, care deeply about this too, and they care because they've spoken with you. So we do feel like we're in a good place for the 118th Congress. The ability to work with both parties on this and and move this forward. The key obstacle for us is awareness. The same way that most folks don't know how to pronounce chronic inflammatory demyelinating polyneuropathy or multifocal motor neuropathy means how would they know how to handle a Medicare coverage problem for that same issue? We have to deliver that message to them. So the more folks that do that locally, the easier it is for folks like Adrian Smith and Earl Blumenauer to move this bill forward. And you're going to hear a lot. This is a message we've been telling patient advocates across the country. This Congress in particular seems very keyed into political issues and kind of grandstanding in front of the cameras. So you're going to see a lot about division and partisanship and gridlock and, oh, is the government going to be shut down on October 1st? A lot of this is just messaging. Even the protracted ability to elect a speaker in the House had a key kind of indicator associated with it. It took them a week to do that, but a week was all the time that they had before real people started to be impacted, before people weren't getting paid that worked in Congress, before you were missing intelligence briefings. So politically, they used as much of that capital as they could, but they stopped short of making a real policy problem for folks. We think that pattern is going to be consistent throughout this year. You'll see a lot of politics, a lot of people talking in front of cameras, but things will also move forward. And just as an example, when Congress was working on the Affordable Care Act and the 4 pillars of patient protection, that hearing where the Ways and Means Committee held a markup for that bill and reported it out was partisan, it was divided, it was a party line vote. And that was what dominated the headlines that night. You know, Congress moves forward with partisan bill. Here's all the pros and cons from both sides. That same hearing, they also considered a number of Medicare bills, a bunch of Medicare changes, the same committee. Those all passed out of committee unanimously, but they didn't make a single headline and they weren't reported on anywhere because there was no disagreement, there was no grandstanding, and there was no political angle to it. So even though you're going to see a lot about how Congress is in gridlock, the process works and they will still move forward with these issues that have bipartisan and bicameral support. In fact, those are likely to be the only issues that they work on and manage to move forward. And they might not get as much attention. They might not end up on the news, but they're important to us. And we should have every intention that they're going to pass the bill, provided we work the process and continue to move forward. So don't ever feel like your member of Congress isn't listening to you or that your voice isn't going to matter because of bigger things that are going on. And I'll say this, I've seen it a dozen times. You might think the person who represents you is not the best person in the world. You disagree with their politics on a number of reasons. But if you go into their office, if you tell them your story, and if you tell them you need help, you should have every expectation that they will respond to you and try to work on your behalf.
Dane, that's a great transition to a quick video that I want to show from one of our volunteer advocates. But Dane, don't go anywhere. You're not off the hook yet with questions, but I just want to help drive home this point of how important it is for advocacy. So also, Dane, let me know if this comes through okay.
I've been to Capitol Hill, talked to some of the senators and congressmen's staff about funding. We have a bill, I think this year it's 3808, which helps our patients get their infusions where they want to, not where Medicare dictates. It allows them to get it at home or an infusion center or a hospital, so it makes it easier for them. I've written letters to help get Guillain-Barré listed on the DoD for defense to get money from their research program. I've done a few video chats when we couldn't go to the Hill. But I have to tell people, when you go to the Hill and you start telling your story, you are the story, and that's what people need to understand. They don't know what Guillain-Barré or chronic CIDP is unless you tell them and show them who we are and how it affects our lives. My first time was a little overwhelming, but I walked away feeling like we accomplished something. Because I spent a lot of time in, I believe it was Lindsey Graham's office, and they asked a lot of questions, and they listened. And when I see them actually writing, that means that I know that they're paying attention. And I know sometimes that's what we need. We need them to pay attention. We do a letter writing campaign just to help with HR 3808, and just for the DoD side, we write letters that way too. I do whatever I can. I mean, I know I'm only one small voice, but that small voice might help.
So that was, I think, a great explanation. Thank you so much, Mary Lynn, for sharing your perspective on that. So Dane, I just wanted to give a quick recap. So you mentioned, all of our advocacy efforts should be nonpartisan or bipartisan, really, and working together in all of this. And you also touched on, sorry, I'm trying to remember. You touched on the importance of all of us coming together in the education. So at the foundation, as Mary Lynn mentioned in her video, we have our Advocacy Action Center on the website to help connect your story and get that to the right place. We also visit the Hill regularly, and as part of our symposium this year, we will be taking a bunch of people up to the Hill. Dane, I hope that you are ready to lead a bunch of teams with us, and that is a great way for people to get involved. So Dane, I want to get back to some questions. You're not out of the hot seat yet. You've mentioned committee a few times. I just wanted to back up, and can you explain the importance of committee in the legislative process? So you touched on this a little bit, but how does also who serves on what committee, how does that influence our advocacy strategy, and how do we move forward?
Sure. So we, at the start of every Congress, they reconstitute these committees. I mentioned that, the speaker dust up didn't have too many real world impacts. Well, one of them was, typically you elect your speaker and then you announce your committee chairs and ranking members, and then you announce all the members of those committees and the subcommittees. They reshuffle the deck whenever there's a new Congress. So if you gain seniority, maybe you want to go to a different committee. If you are new, you need a committee to be assigned to you. But those are that committee of jurisdiction manages your bill. So we really look for two things. We look for just a raw number of supporters. We want all 435 members of the House to be on our bill. It means they know about us, they know about why this matters, and they're trying to solve the problem. But we also want to make sure specifically, and of course that's a little bit of an oversimplification, we want to make sure members of the key committees are on the bill as well, because they have the other members of Congress who are not working on healthcare look to them for guidance. They say, geez, I don't know the first thing about how Medicare Modernization Act of 2003 works. Can you please tell me? And it's going to be someone from their party who's on the committee. So the more people that are on those committees, which is Ways and Means and also Energy and Commerce in the House, the easier it is to move through that process, the markup process, to having the bill reported, moving that forward, in addition to just having a raw number of supporters. We do not yet know who is on those committees, since it took them a little longer to elect a speaker, and the Senate has just kind of been hanging out. They're waiting to come back and start their work. We're waiting on both the House and Senate to announce who all those members are. When we get to look at who are on those new committees, who's completely on all these committees and who are the new folks on the committees, we will create something called a priority recruitment memo. It'll identify like the top 10 states that are most overly represented on healthcare issues in the House and Senate. We really want advocates from those states. We would love for you to join us when we know that information, but I also want to make sure we want everyone to join us, because any member can co-sponsor, any member can weigh in on this, any member can reach out to the Ways and Means Committee and say, hey, this is important to me. Can you please move this forward? If you're going to do a hearing, put this hearing on the docket. And someone like Adrian Smith or Earl Blumenauer, who's trying to help us, can say, look, I've got all these other members who want to move this bill forward. Let's do this on the next hearing or the one after that. So I want to mention really quickly to Chelsea's point, I'm glad the DoD peer-reviewed medical research program was mentioned in that video. That is also a legislative process. That is the same type of legislative process. We asked Congress to put us as an eligible condition for DoD research. It's a list that the government updates every year. And they added us to that list because we asked them to, and because folks on this call and grassroots advocates told them how important it was to have GBS listed as part of DoD research. The difference is that bill is a must-pass bill. It has to go through every year. If we had a must-pass bill for Medicare and health policy, we would feel pretty confident that our request on home infusion would be included, but that doesn't exist. So we have to go through this process of pushing every Congress and then having the bill reintroduced. And I just want to mention, for folks who are interested in advocacy or considering reaching out, we mentioned how, the reason home infusion matters is because for a lot of folks, it's difficult even to get to an infusion center. Imagine how difficult it would be to get to Capitol Hill. So please, if you can, and if you're able-bodied, speak on behalf of others too, even if this issue doesn't personally affect you. But also, if you do have mobility issues, or if you do have something that's a challenge, but you still want to make your voice heard, please go to that action center and participate virtually to the extent possible. You know, these offices are there, these members work for you. So whether you're calling them, emailing them, or trying to set up a Zoom meeting, that all matters as well.
That was really what well said, theme. Strength in numbers, I think, is a mantra that we use a lot. You mentioned the Senate kind of hanging out right now, and there's a question that came in. Once a bill like this passes through the House, how difficult is it to pass through the Senate, or what would that process look like? And I would say, you know, whether this is standalone, or what about if it were to get picked up into some bigger package, like an omnibus package at the end of the year that you mentioned earlier?
Yeah, that's a great point. So just so folks understand, the big champion on the primary immune deficiency disease issue was a guy named Kevin Brady from Texas, who was chairman of that Ways and Means Committee. His counterpart in the Senate was John Kerry. I think folks know John Kerry has not been in the Senate for a long time. So even though Senator Kerry isn't there, a lot of these policy issues still moved forward. And that was because the House was moving them forward. And Kevin Brady was saying this needs to get done. So even though they didn't have a direct person in the Senate, the ability of the House to say this is one of our top priorities still moved that forward. So if the bill passes the House, it is easier to move through the Senate, though we do also try to move something through the Senate on a parallel track to make sure the Senate is equally supportive of this. And we educate our senators too. So if HR 3808 passes the House and ends up in their chamber, nobody says, what is this bill? I don't understand. This isn't one of my priorities. That they all know this is coming and are in a position to help. So we work to educate the Senate in equal measure. And the guy who runs the Senate Finance Committee is a senator, or has been a senator from Oregon named Ron Wyden, who of course is Earl Blumenauer's counterpart. So they are the same party. They're both from Oregon. They're working on the same committees. And Earl Blumenauer, if the bill passes the House, as a way to go to Senator Wyden and say, hey, you have to find a way to get this done. Chelsea brings up an important point, though. Most of these bills that are priorities for either chamber don't get all the way over the goal line. But that's why Congress puts these omnibus packages together at the end of the year. They take all the different bills that everyone agrees need to get finished, and maybe they didn't have time to finish, and they smush them together into one package. So if the bill has passed the House, and if the House is saying this is very important to us, and the Senate is similarly supportive, they can always pass it as a standalone measure, which is not as easy as it sounds because it takes time for them to do that. It takes up part of the legislative calendar. They can't pass every bill they want to. They have finite amount of resources, but you can always try to put the bill in that end of the year omnibus package with many other bills and things that need to get done. So the fact that it's broadly supported and the fact that the committees are supporting it also makes it easier to end up in one of those end of the year, what they call omnibus packages, where they carry a lot of bills forward that they just didn't have time to do through regular order.
Yeah, so there are a couple different options and a couple different pathways here that we can envision. So going back to kind of what is on the horizon for 2023 advocacy, and we've talked a little bit about this, but I think this might be one of the last questions that we talk about. So let's drive this point home. So we've mentioned a couple times that the primary immunodeficiency community had a previous effort that was similar to ours, and they have a benefit that was created as a result of their efforts. So Dane, can you explain a little bit why we don't get to access that benefit? The first thing, before you answer, the first thing I will say is sometimes there is some confusion. You know, CIDP and MMN are not considered primary immunodeficiencies. They are different diseases, even though sometimes people are considered immunocompromised, or your doctor might have said that to you, that you're immunocompromised. You do not fall into the primary immunodeficiency community. So Dane, can you explain a little bit more why we can't access that benefit though?
Yeah, and this comes back to what I was saying about the spirit of the law versus the letter of the law. And Medicare does the letter of the law. So Medicare, I think folks might be familiar, you know, they have diagnostic codes, they have different payment rates for everything they do. And it's very much like an accountant. They follow that directly. So they don't get creative. They don't say, geez, clearly there's a need for home infusion and we have a home health benefit. Let's just stick it in there. They only do what is literally passed in the law by Congress, and they enforce that by dotting every I and crossing every T and doing nothing else. So the reality is with the PID benefit, that for the primary immunodeficiency disease, that benefit is for PID patients, and it's for PID patients based off of their what they call an ICD-10 code. So your doctor has diagnosed you with this condition. He's put a diagnostic code in your medical chart.
Or she, he or she.
Or she, good point. And then that code goes to Medicare when they're doing their billing, and Medicare says, oh, this person has this condition. And there's many different types of primary immunodeficiency disease. So you'd have to go through and list each one of those codes to make sure that you're part of this. If you're not, don't have one of those codes that's expressly listed, they're going to say, oh, too bad. And you might be saying to yourself, well, geez, I'll just go to my doctor and I'll say, hey, just give me the PID diagnosis. And then he or she might say, okay, but then you still don't have access to the benefit because the benefit is specifically for the PID IVIG home infusion. So it's meant to last just 2 hours. It's meant to use a particular volume of immune globulin. And that's how it's done to that finite level of detail. So you'd only probably get 1/4 of what you need. So that's how Medicare works. They're doing this stuff literally based off of what is there. But now that PID has this benefit, there's a known payment rate. They have the codes and everything else for it in terms of infrastructure. That's all being implemented right now. We can go in and say, okay, there's no need to study this issue anymore. We don't need to gather data. We don't need to write 5 different reports on it. We're just going to, it works for the PID community. We have the same, very similar issue, establish and expand that benefit so that it also includes CIDP and MMN in law. The law says for CIDP and MMN2 includes our ICD-10 codes, and then has the appropriate corresponding information to say, this is how much time we need, this is how much IVIG we need, and dealing with all those other issues. So it's similar to the PID benefit, but it needs to be written in a way that makes sure it is broad and comprehensive enough that it covers the complete CIDP and MMN experience, including folks that might have those more intense, multi-day infusion sessions, which is something the PID community just doesn't have to deal with, so isn't dealt with in the law right now. And Medicare has no way to respond to.
Yeah, okay, that makes sense. So let's talk about what are the very, very next steps that what are the next 5 steps that we're going to be taking to help expand the home infusion of IVIG for CIDP and MMN this year?
Yeah, so having the PID benefit blazes a bit of a trail for us. The study is one thing. A study can say anything you want. Lots of times they're doing research and the research study, comes to the wrong conclusion or doesn't end up where they want it to be. A study is just a study. It's not coverage. So we've moved past the discussion about studying and coming up with reports, which is what was going on previously. We've now moved on with the PID community to having a literal benefit in the law. So our next step is going to be reintroducing a bill that says CIDP and MMN need to have a similar benefit in the law, even building on what is there now for intravenous immune globulin in the PID community. And we think we have a pretty good justification. The same way you made this change for them, just make it for us. There are other people who utilize IVIG and make sure that it works for us too. So we're going to be working to fix the bill and make sure it matches with that. We're working with our congressional champions in the House and Senate to make sure that they agree with it, or that they have maybe they're very smart as well. Maybe they have some ideas about things that will cause it to move forward. Getting a new draft of a bill, getting that bill introduced again in the 118th Congress, and then working to gather co-sponsors and push the bill through that committee process and that legislative process that Chelsea was talking about. And the key factor to moving that forward is remembering the old mantra, the squeaky wheel gets the grease. So if we're reaching out, if we're asking for support, if we're getting more members on the bill, if we're telling the committee we need to move this, they're going to be responsive to it. And we will be tracking that closely and trying to move that forward as fast as possible. But the key thing right now is we're coming up with new legislative text. Then the bill will be introduced. We'll have a bill number again. And then the key thing is just going to be building support. Give Earl Blumenauer for the Democrats and Adrian Smith for the Republicans everything they need in the House to get this bill passed through the chamber and have it set up to become law, either through an omnibus package or through Senate action, later this year or next year.
Yeah. Thank you. That's great. And that all sounds optimistic. We're at the 5-minute mark, but there was one question here that I think is worth addressing. It's a little bit of a technical clarification. So since there are a lot of patients that benefit from home infusion, would it be beneficial to include other disease states? And Dane, would it be fair to say, right now, CIDP and MMN are the last FDA approved uses for that IVIG, which is kind of why we are riding the coattails of the primary immune deficiency community, who's the other FDA indicated use. Can you elaborate on that a little more?
Yeah, that's a technical point, but I think there's important grassroots component as well, which is, of course, that when we go to these offices, we're talking to them on behalf of the GBS-CIDP community. So there's probably an MMN, which, but there's probably other issues that you care about politically. You might care about First or Second Amendment items. You might care about, other stuff that you get from other message boards. But when you go in to talk to the Health LA, you're there to talk about this issue specifically, not everything politically that you want to address with the office. You're there as an advocate for the foundation. So the scope of that discussion is narrowed to just these topics. You may go in with them with a different group, a month later and talk about something else, and that's fine. But you don't talk about all of that stuff at the same time. You just stick to these few key points for the community when we have these discussions about the bill. And that makes it easier for the staff to process and know how to respond. If you bring them a litany of issues from everything under the sun, they're not going to know where to start. So we talk about just these points when we're doing foundation advocacy. And we have an opportunity, because the law says that there is a payment right now for intravenous immune globulin. These other folks who need home infusion aren't using intravenous immune globulin. So we are expanding the IVIG benefit that already exists to include us as well. Changing that to include every self-infused drug would become increasingly more complicated, because even the way that there's a difference between PID and CIDP that we have to navigate to make sure the CIDP benefit is big enough to make sure it gets everything we need, and we can't just use the PID one, that would become infinitely complex with other drugs and other communities. The reason this is important for advocacy is that other communities are likely going to their members of Congress as well and saying, I have this problem of site of care switching. I was infusing in the home, however, with whatever, and now I'm going to an infusion center. This happens with multiple communities and multiple rare disease communities. If Congress wants to fix the problem for everybody, that is up to the committee and the leaders in Congress to do. They say, geez, I've done 5 meetings this month, and all these people are saying we need to fix home infusion. Then Congress can tell them how to fix home infusion for everyone. They can pass a bill that says this is the complete new home infusion fix. And we would, of course, have a voice in that process, but it's up to those committees and up to those congressional leaders to decide how to move forward. We just talk about our own issue and say, please pass this bill. Please fix this problem for the IVIG community. But of course, if they responded this year and said, you know what, we're going to pass a bill, we're going to fix this for everyone, that would be fantastic. But it's not up to us to talk about how other communities might need home infusion. We just don't have the technical expertise to say what a different patient with a different disease might need. That's what they need to do with their representative. But if Congress chooses to respond by coming up with a different solution for everyone, then that's their prerogative. But we're here to talk about what the CIDP and MMN patients need specifically.
Absolutely. So Dane, we have about 1 minute left. And the last thing I want to do is I'm just going to share the slide up here. So thanks to everybody for joining and listening in and asking questions. If your question didn't get answered, I have the email here up on the screen. Let me just make sure everybody can see it well. There you go. And finally, I hope that you are inspired to get involved in our advocacy efforts with us. Please visit our website, gbs-cidp.org, and under the advocacy section, you'll find the Advocacy Action Center. And then please consider attending our Alexandria, Virginia, our DC symposium in the beginning of October, where we will be going to Capitol Hill to talk about these issues. Finally, thank you to our sponsor. And then Dane, I can't thank you enough for taking your turn in the hot seat and answering all of these questions. I'm sure that we'll be hearing more from you, but do you have any last thoughts that you wanted to share?
No, I'm just glad that these questions were very detail oriented and, show that folks have a familiarity with what's going on. And that, having that type of personal experience is what will help make sure that your elected officials understand this and feel a need to do something as well. So please, share those exact stories and tell them, your experience with these very questions that you've been bringing forward.
Yeah. Well, Dane, you sound like you're very excited for our 2023 advocacy efforts, and I hope that you've inspired everybody else to be just as excited. Thank you again for attending. We did record this and it will be on the website, and we will see you for our next Ask the Expert session, which will be at the end of February. So stay tuned, make sure you visit our website. Thank you.